everyone, I'm Emma Eggleston, Dean of the WVU School of Medicine, Eastern Division. Tonight's mini-med school topic is obstructive sleep apnea. So OSA, as it's known in short, is a really common condition across the U.S. and here in West Virginia, and one that can carry with it a multitude of other health complications. Luckily, there are also ways to treat it. We are fortunate tonight to have Dr. Levi Stevens here with us to walk us through the details of OSA, what it is, how we can diagnose it, and how we can treat it. Dr. Stevens joined us here at the WVU Eastern Division as a faculty member following completion of his ENT surgical residency program at WVU. He also completed medical school at WVU and is a native West Virginian. Welcome, Dr. Stevens, and thank you.
Good evening, everyone. I'm Dr. Stevens. I'm a new assistant professor here at the Eastern Division WVU School of Medicine and a new ENT in the area and practicing at the hospital as well as Jefferson County. So, good evening. This week is Sleep Awareness Week. I was asked to give a presentation on a topic that myself as an ENT deals with on quite a frequent basis. I see several patients each day. The topic is obstructive sleep apnea. So we back up a little bit and we want to talk about what is apnea and what is sleep apnea in general. So apnea just means basically a pause or a slowing or complete stoppage of breathing. You can have several different types of apneas. There are central sleep apneas as well as obstructive sleep apneas. Central sleep apneas deal more with the brain signaling you to breathe and interference with the ability for the brain to initiate you to breathe. What I'd like to talk to you today about is obstructive sleep apnea, which is a little bit different situation. Obstructive sleep apnea, if you're not aware, it's a very common sleep disorder. One of the most common sleep disorders other than just general insomnia or mild snoring. There's 3 million new cases diagnosed each year, so it's very, very common, very prevalent. In a basic sense, it is a complete or partial blockage of airflow in the upper airway. It really doesn't have as much to do with the lungs, but more the soft tissues in the back of the throat, the tongue, and there's several different anatomical areas, and we'll talk about that later. Really, the severity of the resistance or blockage and the amount of airflow leads to different severities in obstructive sleep apnea. And on the mildest case, when it's not diagnostic of obstructive sleep apnea, snoring, you can think of snoring as the mildest form of this that does not get severe enough to necessarily require treatment. You see that UARS, that's upper airway resistance syndrome, and that's just to note that this all exists along a spectrum from mild to severe, with UARS not quite meeting criteria for obstructive sleep apnea, but it is out there, and sometimes we have to have a discussion with patients regarding that. So again, you have a block in airflow, which that leads to what we call an obstruction. This is usually caused by the soft tissues in the back of the throat. We will go over the anatomy later. I have a nice diagram to show you what I'm talking about. These blockages don't occur all the time. They can occur intermittently for short, brief periods of time. But if it is a long enough time, these pauses can cause a drop in your oxygen level and cause you to wake up or cause an arousal. And even if you don't completely consciously wake up, just these micro-arousals throughout the night can lead to poor quality sleep. Not only does it lead to poor quality sleep, it can lead to poor performance during the day, and then can lead to long-term health issues. And that's why it's so important to be aware of it and get it treated. So who is at risk for obstructive sleep apnea? So it's more common in men, it's more common in postmenopausal women, and more common in the aging population over 65. However, it can occur in children, it can occur in middle-aged individuals, it can occur in many different individuals that you might not suspect. But we do know that, especially in children, if they have enlarged tonsils, enlarged adenoid tissue, these usually shrink when you become an adult. But as a child, these can be large and be very contributory to obstructive sleep apnea. Also, a family history of obstructive sleep apnea puts you at higher risk. Obviously, excessive weight collected in the back of the tongue and in the swallowing tube area can definitely lead to or predispose you to obstructive sleep apnea. I will say not all people that are obese have sleep apnea, and not all sleep apnea is in obese people, but it is a very common link. Also, more solid anatomy, if you have issues with jaw positioning, if you have a small chin or jaw or retroussed jaw, it can also lead to similar issues. And I put this high blood pressure in here. There is an association with high blood pressure, and the thought is that long-term untreated sleep apnea can lead to or make underlying blood pressure issues worse. So what do we need to look out for as far as signs and symptoms? First of all, a lot of times we're not aware of how we act during sleep because we're asleep. And even if we're having some awakenings, that we don't have a complete picture. So talking to your sleeping partner or anyone that is around you to see what they think is a very important first step. So as far as nighttime symptoms, snoring, loud snoring. And not all snoring is diagnostic or consistent with a future diagnosis of obstructive sleep apnea. But if there's a loud, bothersome, persistent snoring, that's when you have to think more about obstructive sleep apnea. The biggest, more specific finding is seeing actual pauses in the breathing. Sometimes you'll see pauses for 3 or 4 seconds. It depends on the time. But a lot of times it's this breathing interruption, and then it's followed by a snorting or loud snoring sound. Sometimes if it's more severe, you can get frequent gasping or choking sensation, moving around in bed, restless sleep, tossing, turning, sudden jerks with awakenings. All these things can be a sign that there's an underlying obstructive sleep apnea or sleep apnea in general. All this leads to poor sleep quality because you're not getting a full night's sleep. Again, if you're not completely waking up, you still can have these what we call microarousals, which change the level. You have different, the architecture of the sleep, you go through different depths of sleep in the sleep cycle, and this causes you to raise to a higher level or a more awake level. Daytime. So, of course, if you're not getting a good night's sleep, you're going to wake up tired. You're going to stay tired. Some people will say they've slept 8 hours, 10 hours, but they still feel like they did not even go to sleep or get a night's rest. Other things that you may not suspect as much, morning headache is very, very specific to this, as well as a dry, sore throat. That's a lot of times due to snoring or very strenuous mouth breathing that leaves a dry, sore throat. Again, excessive daytime sleepiness, and that can be along a scale, and I'll go over a scale that you can use at home as a screening tool that can kind of quantify how sleepy you are. We all live busy lives, stressful lives. You know, there's certain amounts of sleepiness or fatigue or tiredness throughout the day, but this scale I'll show you is good to show what's normal and what's abnormal. Depression and anxiety. So anytime you have a poor quality of life, poor sleep, anxiety and depression can be associated. Decreased libido. Acid reflux. If you're having acid reflux symptoms, heartburn, feeling of sour taste in the back of the throat, and it's primarily occurring at night, waking you up, or in the morning, and you're not having issues other times of the day, you may want to think about it could possibly be influence from sleep apnea. And then blood pressure issues. So if you have elevated blood pressure issue, I already mentioned that. So this is the Epworth Sleepiness Scale score. It's not specific for obstructive sleep apnea. It's just a general sleepiness scale. It can be used and be helpful in people with narcolepsy, which is another sleep disorder, and can be used in various numbers of ways, but we do use it in ENT when we ask people about obstructive sleep apnea screening. So if you look up here, basically it's a pretty straightforward thing. It's 0 through 3 on how likely you are to doze, and then you have 8 different scenarios in which you can score that. Usually, in general, a score of 10 or more, you need to be asking your doctor about, do I have underlying sleep apnea, what needs to be done, because that's considered abnormal. So I put this big anatomy diagram here up to kind of let you know and show you the different areas that we think about when we think about obstructive sleep apnea. If you look there at the back of the tongue, if you look at what we call the soft palate right here, and then you have the back of the tongue here, you have your normal, what we call the tonsils, what most people call the tonsils, those are the palatine tonsils, as well as the adenoid tissue. Usually this is the area of interest when we're thinking about what is the cause of obstructive sleep apnea. So you can have falling back of the tongue base, you can have a large tongue base, you can have issues with muscle tone. Often if you're gaining a lot of weight, and people that are obese, they get a lot of fat accumulation there in the back of the tongue. So obviously if this pushes back, so air would normally want to flow through the nose or through the mouth, down back through here, and into the airway here. This is what you call your trachea, your swallowing tubes back here. So if anything pushes back and obstructs here, of course, that's what we call obstructive sleep apnea. Again, big tonsils in kids, as well as these big adenoids. Adenoids can obstruct the entire back of the nasal cavity sometimes, and then the palatine, or normal tonsils, they can obstruct and push the soft palate back this way. You can also have more rare things, like this is called your epiglottis, and it drops over your airway when you swallow. This epiglottis here sometimes can be pushed back. It can be pushed back by the tongue, or it can just sit in a further back position. The soft palate itself is sometimes very low hanging, all the way down to even like right here. So sometimes the soft palate itself collapses back. And you may be able to get some breathing through the mouth, but in general, most individuals are nasal breathers, whether you realize it or not. When we think about the nasal cavity, this is more so a rigid structure, and it's not as collapsible as these things back here. A really deviated septum, which divides left and right, or really congested nose can lead to issues with CPAP, with obstructive sleep apnea, but it does not it's not as correlated as these soft tissues down here. All right, so now that we've talked about anatomy and the areas of interest, so can obstructive sleep apnea be dangerous? Of course it can be dangerous. The most obvious reason why is if you're having fatigue and sleepiness during the day, normal activities that we would normally not be as vulnerable, such as driving in the car, such as operating machinery, such as if you're doing work in high-risk environments, being sleepy all the time also leads to forgetfulness, memory problems, attention issues, difficulties with attention to detail. And if you're in a work environment driving your car, you're more likely to fall asleep and have accidents. There's been reports of people leaving the stove on, causing house fires, people with young babies or young kids that fall asleep and inattentive to things. So, those are the obvious things. If you're sleepy during the day, you're at higher risk for that. Also, as far as chronic health issues, basically, when you have strain on your breathing system, having strain trying to bring air into the lungs, it can lead to something called pulmonary hypertension. It puts more strain on the heart. It can lead to issues with already existing underlying heart issues, as well as issues with blood pressure. It can make diabetes less controlled. And anytime you're having issues with the blood pressure, the blood vessels, it puts you at a higher risk of stroke and then even early death. So how do you know that if you have sleep apnea? So if you have the symptoms that I've talked about, if you do the sleepiness scale score and it concerns you, if it's enough to concern you, then it's good evidence that you need to talk to your doctor. Okay, so that's the first step. If you come to a shared decision with your doctor that yes, there's a concern for sleep apnea, the next step is getting a sleep study, and that's called a polysomnogram. This can be performed at a sleep center. It's set up kind of like a hotel room, and you go and they hook some monitors up to you. They're watching your breathing, they're watching your heart rate, they're watching your oxygen levels, and they record all these values overnight. Sometimes you can get sleep studies done at home, and they give you the equipment to take home, and you can do it in the comfort of your own home. And that just depends on different specifics. So how is obstructive sleep apnea treated? So there's a multitude of different treatment options. As an ENT, I'm more involved in the surgical realm. But it really depends on the severity and the underlying cause. Again, you can have sleep apnea for multiple different reasons in the anatomy, and it can be mild to very severe. Conservative measures, if there's 3 different classes of severity of obstructive sleep apnea. It's not really of much importance for this talk, but in general, if you're in the mild category, sometimes just if there's an issue with weight, sometimes just diet, exercise, and weight loss is enough to completely reverse the sleep apnea. Sometimes people, if they're have heavy alcohol intake, or not even heavy alcohol intake, just alcohol intake close to bedtime, that can relax your airway enough to where it can push you over the edge and cause an underlying sleep apnea. And just avoiding alcohol can help things. Sometimes just changing sleep position. So it's more common to have an obstructive event or restriction in the airway if you're lying on your back. And that's just the way the anatomy is arranged. That's the way the tongue falls back, the soft palate falls back. So sometimes just adjusting the way you sleep, turning on your side or laying on your face can be enough. Some people will even do what's called a tennis ball trick, and they sew a tennis ball onto their pajamas on the back, so that they'll roll over to the side or roll over on their face, and if they try to roll back over on their back, of course the tennis ball will keep them from doing so. And maybe early on that may wake you up just as much as sleep apnea does, but that will be a learned habit to stay away from the tennis ball. So, in mild situations, there's also something called an oral appliance, and I'll go over that later. But when you get into the moderate and severe category, usually the first recommended treatment is CPAP, okay? And that's continuous positive airway pressure. There's different types. There's things called BiPAP. There's a thing called APAP. But in general, it's a very commonly used device. Air is blown through either a full face mask or a smaller face mask, or even an insert in the nose called nasal pillows. It blows an air column through the upper airway and helps work like a pneumatic splint or like an air compressor. And those collapsible vulnerable areas like the back of the tongue and the soft palate are gently expanded. This is the gold standard. There's no treatment that is better than this if CPAP or any type of positive airway pressure is tolerated. And then often, I just mentioned, often just to hit home that snoring is the mildest form of what is along a spectrum of obstructive sleep apnea, because snoring is basically vibrations due to increased resistance in the back of the throat. Usually the soft palate, can be due to the tongue. So people will notice if they have sleep apnea and they're using CPAP, the snoring is usually decreased or completely taken away. So other treatments, so often patients have issues with CPAP because CPAP, has to be a very tight seal over the face. The straps can cause headaches. The straps can irritate the skin. There's issues with transportation if people work shifts and travel. There's issue with people with beards as far as the mask fitting and getting a seal. People sometimes complain of claustrophobia or feeling, of discomfort or uncomfortability when they have their a full face mask on. The CPAP machine does have a moisture setting, but it can cause dryness and issues with that. So, like again, as I was saying, for mild obstructive sleep apnea, there is another option. There's something called an oral appliance, and it's placed in the mouth, and it helps protrude the jaw forward just enough to help alleviate some obstruction behind the jaw. And if you go back to this picture here, here's the jawbone here, okay? This is another thing called the hyoid bone. But if you just if you just gently push the jaw forward, it can help alleviate and relieve obstruction here. Usually certified dentists or oral surgeons, we get them on board to help with that, because if you have issues with your bite or you have underlying issues with your jaw joints, we want to make sure that we're not affecting anything as far as your bite long term and discomfort in the TMJ jaw joint area. So the other option for people that can't tolerate CPAP, they've tried an oral appliance or they don't qualify for an oral appliance because they have moderate to severe sleep apnea, is surgery. And again, I've already kind of talked about, the different areas that could possibly be targeted. There's not one surgery that's a cure-all. There's not a one-size-fits-all surgery. It's geared towards looking at the anatomy and seeing where the specific areas of collapse are. But as far as surgery, there's surgeries to shrink the tongue base. There's surgeries to straighten up the nose, actually sometimes so people that can tolerate CPAP more so. And sometimes can tolerate the CPAP at a lower pressure, so making that nasal airway smooth. In kids, taking the tonsils and adenoids out, or even in adults, if those are big, taking the tonsils and adenoids out can be, in some kids, it can completely reverse their sleep apnea. There are palate shortening procedures. There are procedures to move this epiglottis forward or actually fix it to the tongue so that it doesn't fall back. And this is showing the lingual tonsils here. Sometimes it's just the lingual tonsils, it's not the tongue, but the lingual tonsils are really big and you have to shrink those down. There's some new technology. One is called a hypoglossal nerve stimulator. And it's basically an implant that goes in the chest wall and senses your breathing or your effort to breathe. And then there is a stimulating lead that stimulates the tongue to protrude. And it stiffens and allows the tongue to move forward, again helping the collapse in the back. So there's a multitude of different procedures. I could spend all day talking about those, but in general it's not a one-size-fits-all. If you're not tolerating CPAP, you would come and see a physician like me, a surgeon like me, and we would do some sort of airway evaluation, usually with a little camera, and see where the area of concern is and see if there's something we can reverse. Surgery is not the gold standard. CPAP is the gold standard. If you look at all the studies and data out that's been published, there's no one surgery that's as effective as CPAP. So CPAP is step one, but if you're not tolerating CPAP, there are other things to do. So as far as take-home points, things that you want to keep in your mind, the big take-home points are, if you're having do the Epworth sleepiness scale. Talk to your healthcare provider if you or your loved one is having these type of symptoms, ask about a sleep study. If they agree to do a sleep study, okay, that's getting you on the right track. If you're overweight, if your BMI is over 30, diet, exercise, and weight loss is very important. And even in people that are moderate to severe sleep apnea, you may still need treatment for sleep apnea, but diet, exercise, weight loss can make CPAP much more tolerable at lower levels and sometimes reverse things or get you to a level where you're much more comfortable with the treatment. Avoid alcohol, especially prior to sleep. So I just wanted to list some different websites. You can get more information about obstructive sleep apnea and sleep issues in general, especially from the American Academy of Sleep Medicine. The American Sleep Apnea Association is good for all types of sleep apnea. American Thoracic Society has a lot of good resources, and then I put my own ENT, American Academy of ENT website on there as well. So I just want to thank you for joining me this evening. If you have any issues in the future, come and see me, and we'll try to take care of you.